Extract 1. Questions 1 to 12. You hear a vet talking to a pet owner called Toni Davies. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Oh, she's fine overall. I just think it's time I did something about this.
What seems to be the problem?
Well, recently Bubbles has been acting a little bit strangely. When I take her to the park, for example, she'll pick fights with the other dogs just because they're, well, there. She barks so loudly, it's really embarrassing. Then don't get me started about when she sees any males about. She acts really, well, randy. I've had Bubbles since she was a puppy, so I know when something's up.
Remind me how old she is now?
She's 2.
All right, and what are you suspecting?
I don't know. I was reading around on the internet about what happens to a dog when she's in heat, and she's displaying all the usual signs.
Is Bubbles your only pet?
She is. We were considering another, maybe a German Shepherd or a Dachshund, but I don't know if she'll be able to cope with that.
I understand your concerns.
Will she always be like this? Is there something we can do? It's getting to be a right pain. The neighbors have a pit bull, and the other day I caught him leering at her. He got pretty violent. We've got a huge hole in the fence that I'm pretty sure was down to him trying to bash his way through.
Have you ever considered spaying Bubbles?
What's that?
It's abdominal surgery to prevent her from becoming pregnant. The medical term for it is ovariohysterectomy, when both the ovaries and uterus are removed. She'll have a faint scar on her tummy, but other than that, you won't be able to see anything. She'll be much calmer afterwards, and you won't have to worry about annoying or messy heat cycles.
Oh, goodness, no, I wouldn't want to hurt her. Is there any other way?
Don't worry, it's a relatively painless procedure, and it's all done under anesthetic, and it's over within 2 hours. She'd come in, we'd give you the painkillers for her afterwards, too. Plus, an Elizabethan collar to stop her from interfering with the stitches. There are other health benefits, too.
Really? Like what?
Well, for one thing, it'll reduce her risk of contracting breast cancer or a womb infection, which is something that can be fatal. Plus, pregnancy in dogs can be quite a big risk that can produce medical complications. The list is endless, really. I can only imagine that she creates quite a bit of mess around the house when she's in heat.
You've got that right. All of those months we spent getting our house trained, and now this. Okay, I think it's something that I'd like to do. Like you say, there are lots of health benefits, and I'd like Bubbles to live a long time. Plus, I'm sure you've done this plenty of times before.
Oh, absolutely. It's a common procedure.
It sounds like there are a lot of positives, but what about the drawbacks? Will she change at all?
Her metabolism will likely slow down after she's spayed, so you'll need to feed her less and keep up or gradually increase her exercise routine.
Okay. If you think it would help, how soon could we have this done?
As soon as next week. I'll check to see if we have the space. Just make sure she hasn't had anything to eat beforehand. The food could react with the anesthesia and make her feel nauseous.
Okay. And you say it'll all be done within a couple of hours?
Yes.
What about after the procedure? My partner and the kids have got into a routine with Bubbles now. We each take turns to feed her and walk her. Can we just carry on with our normal routines?
Absolutely. The day after the surgery, she can eat normally. One thing I would say, though, you would need to limit her exercise for about a week after the surgery. I'd also keep her indoors for a little while.
Okay. So we just ease her back into the routine?
Right.
Okay. I'll discuss it with my partner, make sure he's okay with it, and then I can call to book in if that's okay.
That's absolutely fine. Take your time. It's a major decision.
Extract 2, questions 13 to 24. You hear an occupational therapist talking to a patient, Miguel Castilo. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look up the notes.
Come on in and have a seat, Mr. Castillo. Make yourself comfortable.
Thank you, sir.
You're welcome. Before we start, I'd like to check a few details with you if I can. Your date of birth, please.
18th September, 1981. And I know what you're thinking. Yes, I'm a typical Virgo. Headstrong and resourceful.
All right. What do you do, Mr. Castillo?
Mr. Castilo is what my bankers and lawyers call me. You can call me Miggy, and I'm a bouncer for Voga Clubs Limited. They're the ones who arranged this session for me on account of my alcohol misuse.
And do you have problems with alcohol?
I don't think I do, but I bet you knew I was going to say that, right? If you ask me, my boss's concerns are misplaced. They should be way more worried about the anxiety I've had since late 2017 than this. At least that was medically diagnosed.
I don't think they'd be concerned for no reason.
No, I guess not. I've been hitting the bottle a lot recently, and I guess it's getting more and more difficult for me to hide it. I have these episodes. I go hard at it for a good few bottles, and I think all that concentrated spirits intakes, it's wreaking real havoc on my gut. You've got to understand, though, I'm surrounded by this stuff every single night. I'd not give a flying fig about Voga's concerns if it wasn't for my family. It's the effect on my responsibilities as a papa that brought me here, not Voga's pretense that they give a...
The head of HR called Miggy. I think they care, and you should give them credit for that. You mentioned your family. How long have you been married?
I'm not. I've been with my partner for 10 years, but I never married her. We've just had a little boy together. He turned 1.5 yesterday, and I love him more than I ever thought possible. Even if he looks nothing like me and everything like his mother.
Congratulations to you both. So, back to your employer's concerns. Was it just the drinking?
No, they ranked me over the coals for timekeeping. I can't remember the last time I turned up to a shift on time. It's caused a few rows between me and my immediate supervisor. In fact, the last time got a bit violent. Management's used to the bouncers getting a little aggro from time to time. But I guess they draw the line at violence towards clients.
So there's blows between you and colleagues and customers. Miggy, you know this can't continue. First, we've got to work on breaking the dependency. I spoke with your HR at length, and they've agreed to give you time off so that you can work on yourself. In specific, we're going to go over some coping strategies, which we'll create and rehearse so that you don't have to turn to liquor. There are 2 types of therapy that we use here, and I think that the one that suits you requires us analyzing when you have these episodes, what triggers it. This is called the diagnostic model.
I like the sound of that. I'm keen to get to the root cause of my problems.
Good. Our previous results are very strong. In fact, we've had a 200% success rate that we're very proud of. We'd love to help you too.
That is the end of Part A. You now have 2 minutes to check your work.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25.
You will hear a lecture based on the subject of attention deficit hyperactivity disorder.
Now read the question.
What are the symptoms of ADHD? Most kids could be described at some point as inattentive, impulsive, or hyperactive. Explanations for this behaviour vary widely, ranging from the child being overtired to overexcited. However, when such behaviour lasts for significant periods of time, and when it interferes with life at school and at home, the explanation may be due to a condition such as attention deficit hyperactivity disorder, or ADHD. Some studies suggest that about 2% of primary school-aged children have ADHD, while others have suggested that almost 18% have ADHD. However, the majority of researchers put the figure at between 5% and 10%.
Question 26.
Test, you will hear a talk based on an essay published by the Public Library of Open Science on the topic of seasonal hunger.
Now read the question.
Most of the world's acute hunger and undernutrition occurs not in conflicts and natural disasters, but in the annual hunger season. This is a time of year that is characterized by a lack of stored food from last year's harvest, high food prices, and lack of jobs. Nearly 7 out of 10 hungry people in the world, or about 600 million in total, are either landless rural labourers or members of small farm households. Many of these 600 million people live in areas where water or temperature constraints allow only one crop harvest per year.
Question 27.
Part of the test, you will hear a lecture based on the subject of chronic obstructive pulmonary disease.
Now read the question.
Chronic obstructive pulmonary disease, COPD, is a growing global epidemic that is significant in both developed and developing countries. Morbidity and mortality from COPD will rise as populations age. Furthermore, as the mortality from cardiovascular and infectious diseases falls, the occurrence of COPD will become more common in society. This is supported by the current trend, which indicates that more people are dying from COPD each year. In addition, COPD is associated with several other diseases, such as osteoporosis, diabetes, glaucoma, and sleep disorders.
Question 28.
Dr. Brian Fleming interviewing a parent of a child presenting today.
Now read the question.
Come in, Mr. Murray. I see you've got Kate with you.
Yes, that's right, Doctor. She's had an accident at school.
Oh, dear. Well, I'll bring you both in here and get Kate comfortable on the couch first.
Oh, good. I think she's in quite a bit of pain.
Yes, obviously, and she's looking very pale. Now, can you tell me what happened?
Well, she had a fall at school, actually. It was in her gymnastics class, and I don't know, I think she landed awkwardly in one of the practice exercises.
And how long ago was that?
Well, the school called me to pick her up, and I came straight here, so about an hour ago, I think.
Question 29.
Dr. Tamara Kayali Brown is a bioethicist at Deakin University. She specialises in the ethics and philosophy of mental illness.
Now read the question.
Okay.
I asked for women who had been diagnosed with major depression or bipolar disorder because I wanted a variety of different types of depression, and women who had gone through treatment and were feeling better. I only wanted women, though, because gender issues in depression had already been studied quite a bit, and I wanted to focus on experiences of depression. So rather than including different genders and comparing them, I just wanted one gender. And it made sense for me to focus on women because, first of all, there are more women diagnosed with depression than men. And secondly, I'm a woman, and there is some evidence out there that there are more open conversations that happen between people of the same gender. So it made sense for me to ask for women.
Question 30. You hear us.
Emily Johnson is a neurologist at Johns Hopkins University School of Medicine in Baltimore, and I spoke to her earlier.
Now read the question.
I think most people are surprised to hear that. We often think of epilepsy as being a childhood disease, and it is common in children. Then the incidence kind of tapers off in adulthood and in midlife. But then by the 60s and especially by the 70s and 80s, the incidence of new cases of epilepsy is actually higher than it is in children. So a lot of people are surprised to hear this.
What kind of epilepsy is it? Because there's various kinds of epilepsy. You can get major seizures, you can get what's called petit mal or absence, behavioural things that happen. Is it stock standard epilepsy where you drop down and convulse?
Great question. It doesn't necessarily have to be, although that can certainly happen. But then the other type is called focal epilepsy, and that is the type that starts in one part of the brain and then can spread to other parts.
You hear an interview with a physician called Dr. Tadita Hussain, who's talking about treating patients with cystic fibrosis.
Cystic fibrosis is a condition that causes mucus to be thicker and stickier than it should be. Dr. Tadita Hussain specializes in cystic fibrosis treatment and is here to share her thoughts on caring for people with the condition. Tadita, can you tell us a bit more about patients who suffer from cystic fibrosis?
Absolutely. Sufferers tend to carry 2 to 5 times as much salt in their bodies as those without the condition, so you can see why their mucus is thicker than average. Treatment for these patients is usually quite time-consuming and repetitive. Patients are often required to stay in hospital for long stretches, and as the symptoms of the condition begin to present very early on in the patient's life, many of my patients are young people, and so we tend to see lots of patients with cystic fibrosis finding these hospital visits frustrating.
Right.
In fact, throughout the UK, about 80% of patients with cystic fibrosis who are hospitalised report feeling at least minimal levels of depression.
How about young patients who aren't currently hospitalized? What can be challenging about their treatment?
Well, patients can be required to take around 30 pills a day to keep cystic fibrosis under control. So it's understandable that teenagers and young people who just want to be free and independent might resent this ordeal if they think they can get away with it. One of the most difficult things we have to contend with is the fact that if patients stop taking their medication or doing their daily breathing treatments, their condition won't immediately worsen. Instead, it will gradually become more severe until they contract a serious infection, which puts their lives at risk.
So, what approaches do you use when treating patients with cystic fibrosis?
Well, we've found distraction therapy to be extremely useful. We're incredibly lucky to have received a donation of a number of virtual reality headsets following their success in a number of treatment trials. We use the virtual reality headsets to transport the patient to outdoor settings, often corresponding to the activities they're required to do with us. When they complete breathing exercises on a stationary bike, for example, the VR headsets display a virtual outdoor bike ride. Our patients find it helpful to pretend to be somewhere else during treatment, and it's often easier for us to administer breathing treatments to patients using these headsets, as they're more relaxed when they're not focused on the actuality of the test.
So, what sorts of changes have you seen in your patients as a result of these methods?
One of my patients, a 24-year-old man with cystic fibrosis who was in hospital waiting for a lung transplant, well, he found treatment very difficult at first. He was preoccupied by his need for a transplant and frustrated by feelings of powerlessness. He would often resist treatment. We started using the virtual reality systems with him as soon as we got them, and it took a while for him to get on board, but when he did, it was like someone had breathed new life into him. Not only did he stop hindering his treatment, he actually began to look forward to it. He's even started helping us to think about other ways we can improve the experiences of our patients, like improving social interaction.
Yes, I understand that there are difficulties involved in patient communication.
We're looking into the possibility of instant messaging functions between patients, and even virtual games that they can play against each other. Unfortunately, patients with cystic fibrosis have to be kept apart to avoid cross-infection. It's just one more cross to bear for our patients, that they can't talk to those going through the same thing.
Right.
Our patients get plenty of interaction with myself and the rest of the staff, but we'd like to make sure they have access to a network of fellow sufferers too, for support and advice.
I see. That all sounds quite futuristic. Are there any other advances on the horizon for the treatment of cystic fibrosis?
Well, there's a new drug that's been in the news recently. It's a combination of lumacaftor and ivacaftor. You might know it by the brand name Orkambi. The drug works by improving the level of water and salt in the body, thereby reducing the thick mucus that causes illness and respiratory issues in those with cystic fibrosis. Even more exciting and futuristic, though, is the possibility of gene therapy, where the genetic mutation that causes cystic fibrosis in individuals is replaced with a healthy gene. This would effectively cure those with the condition and significantly extend the lives of thousands of people and remove the need for lengthy stays in hospital.
Now look at Extract 2, questions 31 to 36. You hear the guidelines given by the physician on how to cope up with Prader-Willi syndrome. You have 90 seconds to read questions 37 to 42. Rejection of kidney transplant. What should I do? Rejection is the primary and prominent complication that may arise after receiving the kidney transplant. Since the individual was not born with a transplanted kidney, his body will consider this new tissue is foreign, and as a result it will try to attack the new kidney to protect the body of the individual. Rejection is a common response of the body after the transplant surgery. Therefore, the patient must take appropriate anti-rejection medicine as prescribed to prevent rejection. There are two types of rejections that occur after the kidney transplant. 1. An acute rejection occurs usually any time during the first year of transplant and can be cured successfully. Whereas a chronic rejection occurs gradually over years. The causes of chronic rejection are yet to be identified by the research, and the treatment of chronic rejection is often unsuccessful. Immunosuppressant or anti-rejection medicines decrease the natural immune response of the body to the new foreign organ. The medicines repress the immune system and prevent the body from rejecting the new organ. However, there are also chances of getting cervical, colon, and breast cancer in women and prostate and colon cancer in men. Significantly, it is very difficult to diagnose the kidney rejection in its early stages. Also, the rejection is often irreversible once it starts. Therefore, the organ recipients should never stop taking the anti-rejection medication, even if they think the new kidney is functioning well. Discontinuing the anti-rejection medication will encourage a rejection to occur. The numerous side effects of the immunosuppressant or anti-rejection medications are usually manageable by the patients. Blood levels after having anti-rejection medications have to be examined regularly to prevent rejection and reduce the side effects. High blood pressure, weight gain, getting infections, and an increased risk of certain types of cancer are some of the common side effects of immunosuppressant medications. The three groups of immunosuppressant medications are induction agent, a powerful immunosuppressant medication given before the transplant or immediately after the surgery. Maintenance agents are the second group of immunosuppressant that have to be taken regularly throughout the lifetime. Rejection agents are the medications that are used for treating the kidney rejection. However, since the immunosuppressant medicines lower the immune system, there are high possibilities of viral and other infections. Therefore, diagnosing and treating the infections at the initial stage is the best method to maintain the body and the new organ healthy. It is very essential to wash the hands frequently or to use an antimicrobial gel during cold and flu season. The patient should report to the physician following any of these symptoms: sores, injuries, or wounds, especially those that do not heal, symptoms of urinary tract infection like a frequent urge to urinate, pain or burning sensation while urinating, reddish or cloudy or bad-smelling urine, symptoms of respiratory infection such as nasal congestion, cough, sore throat, and scratchy throat, running nose, or a fever. There are certain vaccines that will protect the body from infection. Also, certain vaccines are not good for a transplanted patient. For instance, the patient should avoid all live vaccines. Therefore, the patient should consult the transplant team before receiving any boosters or vaccines. The following are the common rules for receiving vaccines such as live vaccines, a flu shot, or hepatitis B. Hepatitis B should be received before transplant. Should avoid all live vaccines. Should avoid the nasal influenza vaccine. Should wait for at least 6 months after transplant or receiving a flu shot. Afterward, get a yearly booster injection. The patients who receive a live vaccine should avoid direct contact with the children received oral polio vaccine for 3 weeks. The children received measles or mumps vaccines. The adults received attenuated varicella vaccine to prevent zoster. The adults or children received the nasal influenza vaccine. The recommended vaccines are Haemophilus influenza B, diphtheria pertussis tetanus. Hepatitis B is safe before transplant. Hepatitis A should be given before traveling. Neuromax, single booster after 5 years of transplant. Influenza types A and B yearly. Inactivated polio. Meningococcus. Typhoid 6. The following live vaccines should be avoided: varicella zoster, smallpox, live oak typhoid, TY21A, and other newer vaccines, intranasal influenza, Bacillus calmette-guerin, yellow fever, mumps, rubella, oral polio, live Japanese bee encephalitis vaccine, and measles, except during an outbreak. The patient may develop diabetes after the transplant even if he did not have any diabetes earlier. This kind of diabetes is known as new onset diabetes after transplant, or NODAT, that can occur as a side effect of the anti-rejection medications. Kidney recipients are often at greater risk for heart disease. The many causes for heart diseases are diabetes, smoking, hypertension, overweight, high cholesterol, blood lipids, hypertension, and prolonged periods of dialysis. There are increased chances of cancer formation after the transplant. Therefore, it is very crucial to keep maintaining the immune system to prevent cancer formation. Since the immunosuppressive medications decrease the immune function, that will obviously decrease the defensive mechanism of the body against certain types of cancer, there are things that you can do to lower your chances of getting cancer. The most common type of cancer is the skin cancer that can result in the fatality of a patient. However, there are also chances of getting cervical, colon, and breast cancer in women, and prostate and colon cancer in men.